Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello, my name is Dr. Mika Shapira Rootman. I'm the head of Pediatric Radiology Unit at Rambam Healthcare Campus in Haifa, Israel, and during the next 30 minutes or so, I'm going to discuss some basic concepts regarding imaging of pediatric neuroinflammation. And obviously, this is a huge topic. We're not able to cover all aspects, just some key concepts that you need to be familiar with. So let's begin. And first of all, what is neuroinflammation? This is a term used to describe the broad range of immune responses specific to the central nervous systems, and it differs from peripheral inflammation, as it involves intrinsic brain cells like microglia and astrocytes, in addition to extrinsic leukocytes. And neuroinflammation also involves this highly specialized form of endothelium, the BBB, the blood-brain barrier, which plays a significant role both in protecting the brain from all sorts of pathogens and stimuli and in regulating its permeability. We categorize CNS inflammation into primary inflammation, in which the initial insult is inflammatory in nature, like multiple sclerosis, as opposed to secondary inflammation, in which the initial insults or initial pathology is non-inflammatory in nature, like stroke or tumor. And when looking at PubMed, we can appreciate here the increasing number of publications in this topic, pediatric neuroinflammation, in recent years. And we are gaining, in fact, more knowledge and understanding of these entities with more treatment options, necessitating a quicker, accurate diagnosis. And us, as radiologists, we should be familiar with the various neuroinflammatory conditions and their typical radiological manifestations. And in this talk, we're going to focus on pediatric acquired demyelinating syndrome, or ADS. Just to clarify, the term demyelination describes the loss of myelin sheath with relative preservation of axons, and ADS are characterized by neurological deficits that persist for at least 24 hours and may involve one of these three: optic nerve, spinal cord, and brain. And the spectrum of ADS has dramatically evolved over the past 2 decades or so, with the discovery of specific autoantibodies targeted against proteins in the central nervous systems, allowing recognition of inflammatory demyelinating conditions that are distinct from multiple sclerosis. We are talking about 3 major conditions: MS, neuromyelitis optica spectrum disorder, the NMOSD spectrum disease, and the myelin oligodendrocytes glycoprotein, the MOG antibodies associated disease, the MOGAD. In fact, in 2004, was the identification of the aquaporin 4 antibodies directed against the main water channel protein in the central nervous system, leading again to the recognition of NMOSD spectrum disease. And regarding the MOGAD, the first association between MOG antibodies and ADEM was reported in 2007. And since then, first of all, the techniques for detecting MOG antibodies has improved dramatically, and MOG antibodies have been shown to be associated with an involving group of demyelinating conditions, and these are altogether termed the MOGAD, as we see here, affecting more commonly children, diverse radiological and clinical phenotypes. So ADS may occur as a monophasic illness, just like ADEM, for example, or as a chronic relapsing condition like MS. And up to 45% of children with ADS will be diagnosed with MS within 5 years, usually relapsing remitting course. And once considered variants of MS, the MOGAD and NMOSD spectrum disease are now we know that are distinct entities, and identifying the different subtypes of ADS. This is especially important in presentation because it has significant implications for treatment and prognosis. This is a diagram taken from a review article from Radiographics in 2020 that I strongly advise you to look at, understanding pediatric neuroimmune disorder conflicts. And we can see here these 3 entities: the MOGAD, the NMOSD spectrum disease, MS. They have some overlap in clinical and radiological features, although the autoantibody biomarkers, the MOGAD, the aquaporin 4, these obviously may differ. This is another table taken from the same article comparing the three entities. So MOGAD oftentimes it may appear after antecedent infection or vaccination, and in children may present with this ADEM-like phenotype, as we discussed before, or corticospinal phenotype. More common in children, the disease course may be monophasic or relapsing. CSF analysis may reveal plocytosis, and the prognosis, it depends. With the monophasic disease, it's usually good, and with recurrent attacks, then patients may accumulate disabilities. Regarding the NMO spectrum disease, quite variable clinical presentations. They may present with optic neuritis or transverse myelitis. Area postrema syndrome. The area postrema is located in the medulla oblongata, in the posterior inferior surface, in the medial aspects, and patients may present with hiccups, nausea, uncontrollable vomiting. Patients with NMO spectrum disease may also present with acute brainstem syndrome, the encephalic syndrome, in which the patients are very thin and weak, although they have normal caloric intake. Symptomatic cerebral syndrome, typical brain lesions that may cause various presentations. The course is typically relapsing more than 90%. On CSF, we might see plocytosis. And the prognosis, again, if we have attacks with high relapse rate, and obviously it may result in disability. Regarding multiple sclerosis, patient may present with monofocal or polyfocal event. Usually they're not encephalopathic or have seizures. The most common pattern, as I mentioned earlier, is relapsing remitting, more than 95% of patients. On CSF, very important, oligoclonal bands in more than 90% of patients. We might see some plocytosis, moderate. And the prognosis, more disability occurs in secondary progressive phase. This is obvious. And now let's begin and look at some cases. So this is a case of a 12-year-old boy with right side weakness and cerebellar signs. MRI was performed. Midline SAG, paramidline SAG, flare sequences, paramidline, parasagittal, T1 post-contrast and axial T2. And we can appreciate here the corpus callosum lesions. This is involving the callosocceptal interface, as you can see here. Brainstem lesions, multiple lesions here in the pons, also in the medulla, midbrain. White matter lesions, these are perpendicular to the long axis of the ventricles or along the course of the veins. We might appreciate some enhancement here, a open ring configuration. And on the axial T2, there are these cerebellar lesions involving here the white matter. We can also appreciate here brainstem involvement as well. So what is the diagnosis? And in this case, we are talking about pediatric onset multiple sclerosis or POMS. So what were the clues according to imaging? So we've seen these bilateral symmetric ovoid lesions, the typical lesion distribution involving a juxtacortical white matter, cortica, also the cortex itself, periventricular white matter, corpus callosum, lesions involving the posterior fossa, brainstem, cerebellum, spine, characteristic perpendicular callosocceptal lesions as we've seen before, and the typical appearance of the periventricular lesions with the perivenular orientation, the Dawson fingers, typical appearance of spinal cord lesions that might suggest, we'll see an example later on, usually single lesions, short segment, oftentimes posterior lateral locations. So POMS is defined as a first MS attack occurring before the age of 18. The pathophysiology is not completely understood, variety of combined causes, genetics, infections, and so forth. And again, the major pattern is the relapsing remitting, more than 95% of cases. The diagnosis of MS requires evidence of dissemination of CNS inflammatory activity in more than one CNS location, which is called dissemination in space, or DIS, and dissemination in time, DIT. When you're talking about dissemination in space, This can be demonstrated on MRI by one or more T2 hyperintense lesions that are characteristic in at least two of the following areas: periventricular, juxtacortical, cortical, infratentorial, and spinal cord. Regarding dissemination in time on MRI, this can be demonstrated by the simultaneous presence of enhancing and non-enhancing lesions on a single MRI scan, or by new T2 or enhancing lesions on a follow-up MRI scan. But as new treatment options do emerge and the importance for earlier diagnosis of MS has led to key changes in the diagnostic criteria, and these are less reliant on stringent imaging criteria. So more recently, it has been recommended that the presence of CSF oligoclonal bands that we've said are quite typical, more than 90% of MS patients. These can substitute for radiological evidence of the dissemination in time. And this may facilitate earlier diagnosis and initiation of treatment in MS patients. Let's have a closer look on the imaging features in MS in POMS. So again, we might see these periventricular lesions that are very typical T2 flare hyperintense lesions that abut the lateral ventricles. As we can see here, no intervening white matter between the lesion and the ventricle. Juxtacortical, cortical lesions, again involving the subcortical white matter with no white matter between the lesions and the cortex. The lesions again may involve also the cortex. Infratentorial lesions that may involve the brainstem and cerebellum. As we can see here, white matter of the cerebellum, brainstem. Tumefactive lesions that may resemble a tumor, larger than 2 centimeters. They may have a surrounding edema, mass effect. The black holes are depicted on T1 with hypointensity, and these indicate chronicity and are the result of severe demyelination and axonal loss. Contrast enhancement is quite typical. Up to 70% of children with MS have contrast enhancing lesions at presentation. These may be a ring or partial ring, open ring, and we'll see more examples later on. This is a complete ring, as you can see here. Regarding optic neuritis, then in MS, this is usually unilateral, short segment, oftentimes anterior segment. We can see bilateral lesions sometimes, but this is not the common presentation. And regarding spinal cord, then these typically involve the cervical region, extending up to 2 vertebrae. Activity can be appreciated by a contrast enhancement after a contrast material administration. So which sentence best describes MS? It's impossible to diagnose the first event of MS without evidence of dissemination in time, according to imaging. The second sentence, the presence of T1 hypointense lesions, the black holes, helps to discriminate MS from ADEN. There is no involvement of cortical lesions on MS, or spinal lesions are usually longitudinally extensive, meaning extending for more than 3 vertebral bodies. So the correct sentence is this one. T1 hypointense lesions, the black holes are very typical of MS. We rarely see them on other entities like MOGAD or NMO spectrum disease. Regarding the first sentence, so according to the revised McDonald criteria in 2017, and we've mentioned it before, patients with typical clinically isolated syndrome and clinical or MRI demonstration of dissemination in space, then the presence of oligoclonal bands on CNF, it allows the diagnosis of multiple sclerosis. Regarding cortical lesions, then gray matter lesions are found in MS associated with cognitive impairment, and according to the 2017 revision, the cortical lesions can be used to demonstrate dissemination in space. Spinal lesions in MS, typically single short segment, involve a small portion of the transverse diameter, posterior predilection, lateral predilection. And this is a companion case, 17-year-old girl with paraparesis, hemiparesthesia, instability in walking, tremor, heat intolerance. MRI again was performed, and we can appreciate these multiple bilateral lesions with high flare signal intensity. These are noted in the juxtacortical deep periventricular white matter, corpus callosum lesions, brainstem, cerebellum, as we can see here. Some of the lesions are enhancing, again, a closed ring in this example. Multiple white matter lesions are extending along the perivenular axis, the Dawson fingers, as we discussed earlier. Regarding the spine, then the spine imaging reveals this very small round enhancing lesion at the posterior aspect, so you can see here, of the cord at T8 level. And this was again a case of MS. Let's have a look at another example. This is a 4-year-old girl with refusal to walk. MRI was performed. We can appreciate these T2 flare hyperintense lesions in the parenchyma. Some are quite large, maybe ill-defined in part. These lesions do enhance after contrast material administration. Although there are no dedicated sequences in this study to the orbits, I think we can appreciate on flare the hyperintensity of the optic nerves bilaterally with anterior involvement, and this large lesion in the spine, longitudinally extensive, involving more than 3 vertebral segments in the axial view. I think we can appreciate this maybe H configuration with involvement of the gray matter. And in this case, the diagnosis is MOGAD. And as I mentioned earlier, this is a distinct CNS inflammatory disease with symptoms and imaging findings that may overlap with other ADS or neuroinflammatory disorders. They may affect patients of all ages, more typical in children, with the production of IgG antibodies to the myelin oligodendrocytes, glycoprotein expressed on the outer lamella of the myelin sheath, and oligodendrocytes. And patients with MOG antibodies, they may present with optic neuritis, transverse myelitis, ADEM, brainstem or cerebellar features, or cerebral cortical encephalitis. And MOGAD may be monophasic or relapsing or have a relapsing course. In adults, optic neuritis is by far the most common onset feature, and in children, more commonly we encounter ADEM with or without optic nerve involvement. Another common presentation is transverse myelitis, and we have less common presentations including cortical encephalitis, the flames, a presentation with brainstem and cerebellar attacks, monofocal and polyfocal presentations, cerebral cranial neuropathies, and quite rare, this progressive white matter damage, the leukodystrophy-like pattern. Brain lesions tend to be bilateral, asymmetric, ill-defined, large, often with deep gray matter involvement, and quite typical is involvement of the pons and middle cerebellar peduncles. This is an example from another article from HANR in 2024 with this ADEM-like pattern with these quite large hyperintense lesions on flare and G2, involving here the juxtacortical deep white matter, involvement here of the bilateral thalami, pons, middle cerebellar peduncles with foci of enhancement. Flames, cerebral encephalitis. Patients may manifest with fever, headaches, reduced consciousness, seizures, and the lesions are most apparent with flare, with this cortical swelling and hyperintensity on flare. Some leptomeningeal enhancement is noted here with associated changes in diffusion. What about the optic nerve? So in MOGAD, we're talking about usually on bilateral involvement. Optic nerves are edematous, enlarged, tortuous, usually involving the anterior segments of the optic nerves, sparing the chiasm and retrochiasmatic pathways, as opposed to NMO spectrum disease. We might also encounter optic disc swelling, and typically enhancement may involve the perioptic nerve sheath and the surrounding orbital fat, presenting in up to 80% of patients with MOGAD. We can see here in this example taken from AJR in 2021 on axial flare. We can appreciate this hyperintensity in the bilateral optic nerves in the anterior segments in the optic disc with some subtle enhancement. This is T1 fat set post contrast. In the right optic nerve, some enhancement of the nerve, the fat, as we can see here. Regarding spinal cord involvement in MOGAD, so typically it's longitudinally extensive, and on axial sequences, we might see these central lesions involving both gray and white matter or the H-shaped with involvement which is confined to the gray matter. Sometimes we may also see the snake eyes with two anterior dots, similar to spinal ischemia. The next case, 11-year-old girl with bilateral optic neuritis, MRI was performed, and again we see these multiple foci of T2 flare hyperintensity. We can see here adjacent to the third ventricle, the thalamus here, so cortical, some are enhancing with involvement of the bilateral optic nerves. These are dedicated sequences to the orbit, T1 fat set with contrast material administration. We may appreciate this enhancement of the bilateral optic nerves here in the posterior segments, maybe left more than right, some swelling of the optic nerves as well. So MRI of the spine was also performed, and we see here this long segment of T2 hyperintensity, longitudinally extensive, involving more than 3 vertebral bodies, with associated patchy enhancement. So in this case, what is the most likely diagnosis? Do you think it's MS? Maybe we should consider alternative diagnosis, maybe NMO, and why? So what are the clues? This is NMO, classically characterized by optic neuritis and transverse myelitis. The spine lesions are typically longitudinally extensive, although you should be careful because longitudinally extensive transverse myelitis may also be found in other ADS, including MS and MOGAD. Most commonly, we see these cervical lesions extending to the lower medulla. The lesions in aquaporin 4, they parallel the distribution of the aquaporin 4 channel in the brain. We can see here from this article from 2016. So we might see periependymal lesions surrounding the ventricular system, again paralleling the aquaporin 4 receptors, involving the diencephalon around the third ventricle, the aqueduct, may involve the region of the thalamus, hypothalamus, the midbrain, dorsal brainstem, and around the fourth ventricle, quite typical, the areas postrema that we discussed earlier, and the nucleus tractus solitarius. We might see these large, often tumefactive white matter lesions. We might see lesions involving the cortical spinal tracts. The typical enhancement pattern described is poorly marginated, patchy, oftentimes described in the literature as cloud-like parenchyma. The optic neuritis is usually bilateral, but in NMO spectrum disease, there is more posterior involvement, unlike MOGAD, often involving the chiasm and even postchiasmatic segments. So, if we want again to conclude and compare the various entities, then regarding brain lesions, MOGAD, we might see these ADEM lesions typical of ADEM. These include these quite often large T2 flare hypertensive lesions. They may involve the supratentorial compartment or the infratentorial white matter, typically pons, middle cerebellum peduncles, medulla. We discussed that these may involve the deep gray matter, quite rare but described in MOGAD, the leukodystrophy-like pattern. Involvement of the corpus callosum in the ADEM is rare. We might see some nodal enhancement. Other phenotypes include the cortical encephalitis. We might see cortical leptomeningeal enhancement, but black holes are rare. In NMO spectrum disease, just like I mentioned, we might see the lesions parallel the distribution of the aquaporin 4 expression, involving the diencephalon around the third ventricle, fourth ventricle, aqueduct, brainstem, the area postrema, again, periependymal enhancement, maybe patchy or cloud-like, but leptomeningeal enhancement is rare. In pediatric onset multiple sclerosis, we see the typical periventricular white matter lesions, Dawson fingers, cortical, juxtacortical lesions. We can see involvement of the corpus callosum. It's quite frequent. Enhancement, ring or open ring enhancement. The black holes are common. Leptomeningeal enhancement is rare. Regarding optic neuritis, so In both MOGAD and NMO spectrum disease, we see bilateral involvement, extensive involvement. The MOGAD is usually anterior. We might see even optic disc swelling, the perineural optic nerve sheath enhancement, while in NMO spectrum disease, there is more involvement of the posterior segments. In MS, unilateral involvement, short segment. Regarding the spinal cord, MOGAD and NMO spectrum disease, longitudinally extensive lesions in MOGAD. On axial, we can see the central lesion or the H sign, sometimes the snake eyes sign. Conus involvement is typical, and we might see enhancement. This may be nodular. We might encounter diffuse root enhancement or leptomeningeal enhancement. While in NMO, the conus involvement is rare. We can see some patchy enhancement, and on axial images, usually the central cord involvement, often with these bright spot lesions with extremely high T2 signal intensity. And on an MS, we are talking typically on these short segments, peripheral on axial images, lateral dorsal columns involvement. Conus lesions are rare. We might encounter multiple lesions. So to conclude, we briefly, very briefly discussed some key concepts in neuroinflammation, pediatric neuroinflammation, and focused on acquired demyelinating syndromes like POMS, MOGAD, and NMO. All three of them may involve the optic nerve, brain, and spine. We briefly discussed the demographics, clinical characteristics, lab, and obviously the imaging features. And we should be familiar with the major imaging characteristics, in addition to these unique features like the H-shaped, the pattern of the optic nerves involvement, and so forth. And by recognizing or suggesting the correct diagnosis early, then we might help our patients and facilitate earlier diagnosis and treatment. So here I conclude. Thank you very much. It was very quick, but I hope that I helped you. This is my email if you have more questions. So thank you. Bye-bye.